you can't change healthcare if everybody is being polite, right? Like there are points where you have to engage in healthy conflict and you have to push each other and you have to debate. And that doesn't mean that there's an issue. That just means that, you're solving a hard problem.
Hey everyone, welcome to Leadership Rounds, a podcast shining a spotlight on exceptional clinician executives thriving and driving innovation at the intersection of business and healthcare. I'm your host, Dr. Reena Pandey, and together we'll explore the wisdom and insights of great healthcare executives and craft a prescription for leadership success, one candid conversation at a time. Carolyn, it is such a pleasure to have you on this podcast with me. This has been a long time coming, and it's just a special treat to have you with me. As you know, I started this little endeavor to shine a spotlight on spectacular clinician leaders who have really thrived at the intersection of business and clinical care. And you are a particularly unique person with the work you've done at Omada and now at Verily. And there's this particular topic that I think we're going to have fun talking about, which is how you've really succeeded at that intersection of product and clinical and digital and business. And that's a tough one that I'm going to enjoy the conversation with you on. So welcome. Thank you for joining me.
Thank you so much for having me. It's always fun to do these things with a friend. So really excited to be here.
Yeah, and I am certain that people are going to enjoy hearing your perspective and your voice. So it's a treat to have you. Well, maybe I almost want to just jump right into the product thing because I think, oh my gosh, I have gotten so many calls, complaints is probably better, from other clinician leaders who have just struggled to find their way talking to their peers who are non-clinicians, be it product leaders or technology leaders. And maybe just start with your background a little bit, and we'll get there in one sec, but just tell us the story, like where you started, how you got to Omada. And then I think this is a topic we should just jump in on because I think people are going to love hearing about it.
Sure. Well, again, thank you for having me. I think for me, it probably goes back to honestly why I went into medicine, which was originally to have impact at a population level. I've always been really interested in preventive health and kind of what starts people off on a behavioral path that leads to chronic disease. And I think that because of that, from the beginning, I've been thinking about doing interventions outside of the clinic. And I think what that comes with is the realization that you're going to have to partner with others. You're going to have to work with others. You're going to have to work with the community. You're going to have to work with clinical staff. You're going to have to work with the government. And so you're going to have to come in with an attitude of, I'm not the only one here with the idea. Everybody needs to work together and we all have to participate. And so that foundation, as I went into med school of public health and public policy, I think set me up for a little bit of a different mindset in terms of how I think about interventions and designing. I think that's a little bit different from how most people come to medicine. I think a lot of people come into medicine are looking forward to being an attending, being able to call the shots. Yeah. And we're trained that way, right? You go through med school and you're trained to think, okay, you're going to write literally the word orders. You're going to order other people around. Right. And so my journey was when I started in med school, right from the beginning, I was doing pediatric behavioral based programming in schools. I was working in the community. And so from the get-go, that was sort of my approach. So my trajectory was I went to med school, again, interested in public policy, thinking about public health, went into pediatrics, did the usual thing, I think like you did, went to the big fancy university hospital, got my big degree, went to another one for my residency.
Yeah, I stayed at the same one for everything.
Yeah, exactly. And then I stayed and I made a plan that I was, going to do research as we do.
Yeah, I'm familiar.
Got everything in place. And the research I was planning to do was health services research in the community. So I started always focused on obesity, did obesity programming in the community, I started a summer program for overweight kids. I did an after school program. I got my feasibility data. I was ready to write my K award. And then the hospital wrote a really big check to Epic. And I had brand new children. And I was really interested in not having to write grants at that time in my life. Yeah. And I signed on to the Epic team. and implemented the EHR. And that just blew my mind what was possible with technology. And I was thinking I could spend my whole career scaling these programs, these community programs with the government or with any kind of partner, or I could instantly reach millions of people through technology. And so it's obvious what the what the right answer is. So I switched to technology. And then when we were done with the Epic implementation, I've always been a little entrepreneurial and wanting to design my own programs. And I didn't really want to implement someone else's technology for the rest of my career. So I left my pediatric faculty position and tried industry. And I always joke with people that I had never sold anything except lemonade up until then. I was a tried and true academic, nonprofit community person. I'd started clinics in church basements. I had done, all of that. I never sold anything. That was more for my brother. You know, my brother. My brother was more the businessman, and he encouraged me. And so I went to a small startup, and then went to Omada, and found my home in Omada for 8 years. And Omada really made at least my dream come true for why I went into healthcare, which was, again, to reach millions of people and through interventions that I had designed. And I couldn't have imagined having a better opportunity and, a bigger impact. And so very, very special. But the thread through all of it was really just this question of how do you impact people in their home and in their community with behavior change, and technology is just the best route, I believe, to that.
Yeah. That sentiment, I think, is probably shared by many of us who've made the leap from the clinical or community or academic world to have impact at scale, and to recognize that, it's good work that you're doing on the ground, right? The community-based work, it's good work, but and people should continue to do that work, right? But then I similarly had that itch of how do you take all that goodness, bottle it up, and make it available, in order to have impact at scale. So that sentiment certainly resonates. I did get as far as the grants and the research and all that before I made my leap. So I was a little slower to figure out that the research path wasn't the way that I was going to have impact. I had to be, using technology and using data to change behavior. It's not a dissimilar concept, that I was itching as a cardiologist, and same theory, right? How do you use technology to help people make change in order to improve their overall health and well-being? And I think the philosophy was so similar to what you guys were doing and building at Omada. So tell me, let's just jump in actually to some of the how, right? Because I do think there's so many clinicians in innovative roles these days, and who are some successful, some struggle to use their voice in a way to really have an impact at the level of product innovation. And I would love to hear your experience and what worked. We'll talk about a lot of it, but what worked, what didn't work. Where did you struggle? How did you overcome those struggles? So let's just, dig in and tell us what your role was, and how you worked with your product peers, etc.
I think that I guess I could proudly / humbly say that I think the thing that made the biggest difference is just my pediatric training, and then also all that community work. I've never worked in an environment where I could just walk in and throw my weight around. I've always had to come in curious, listen, work with other team members. That's been part of my training and my work my entire career. And I think that made me very well suited to the startup environment and the product development process, because it requires that. And I think that mindset of, well, what can I learn from you, regardless of how young you are or how many credentials you may not have compared to mine? I always enter every conversation thinking, what can I learn from this person versus what can they learn from me? And I think that mindset has made a really big difference in terms of my ability to engage with product engineers, designers, anyone in the startup environment. And sure, if I feel strongly about something or I think we're doing the wrong thing, I will definitely throw my weight around and, make my voice heard and we talked a little bit in preparation. I'm sure we'll get to this when I've done those things. But I think for the most part, I just try to lead with curiosity versus judgment, and just try to understand why someone's having the point of view and what's guiding it, even if to my eye it seems really not workable. As an example, you might have an engineer or designer design something that just to your eye feels completely unusable clinically. And instead of saying, hey, that's unusable clinically, I'll usually say, hey, can you tell me why you built it that way? I just would like to know, because from my eye, that's not usable, but I'd just like to know what was driving you. And there's always a why, right? And want to get, if the goal is to get that visualization, as an example, fixed, it just doesn't work to come in and say it needs to be fixed. And that's really hard for a lot of clinicians, because we're the attending. We're used to coming into a hospital and quickly telling everybody, hey, this is what we're doing today. And everyone does it.
Exactly. Yeah, exactly. I love what you said about like, what can I learn from you? Right? Not just here, I have the answers, but people come with varying expertise, right? We were chatting about how, we may come with our big degrees, but other people actually also come with their big degrees sometimes, right? Like your PhD, or you're, from MIT or what have you, maybe on your technology team, right? And coming at it with curiosity, with intellectual curiosity, and a perspective of what can I learn from you? What can I share? And what can I learn from you? I think is remarkable. Can you share an example of where, actually share one where like you might not have done that? Because I've certainly there are certainly walked in like guns blazing, like this is how we practice medicine. You can't like build a product like that. And then I'm
a human being. I don't wake up every morning with a smile on my face. Like on those days when, listen, the kids are driving me nuts and time is short, and I have my moments for sure.
Totally.
And I think, there are these moments where, and I know you've had this too, where you get hit. I like to use the word hubris. You get hit by this just honestly ignorant hubris that comes in the technology world, that is very off-putting to me. And you'll be in a meeting and someone will, because they had one clinical experience, or they knew somebody, or they read something, they believe this is what we should do. And the challenge is, in a technology environment, sadly, often the product team or the business leaders get the final call. And that can be really difficult as a clinician, because you believe so strongly that the call they're making is not the right call. And so the example that I can give you is, I have a fun one. So we were at Omada. We were building. We were really racing to get our diabetes program out the door. We had a deadline, as everyone does. We were marching toward that deadline. I was feeling the stress of that because I was responsible for it. And we were looking at the final data visualizations, and the team had made a visualization of hemoglobin A1C, a basic diabetes metric. And when I was reviewing the visualization, they had one value in the screen, and I said, okay, where are the other ones? And they said, well, that's the most recent one. And I said, that's great. That's very helpful. But as a clinician, I want to know the trend, and I want to know the back and forth. And they said, oh, well, you're going to die when you hear this. They were like, well, we don't have the other ones. And I said, why? They said, we overwrote them.
Oh.
So because they didn't know.
Sure,
they didn't know.
Sure. They just saved the most recent number, thinking that's the
most recent number. And then I said, well, where are the other ones? And they said, well, we overwrote it. And I said, well, we have to go get them because first of all, it's someone's, and it was there. It was in the system. It just wasn't being visualized. Yeah. And so we were able to get the trend going, and we were able to explain it. And then we had a really interesting conversation as well about how all A1Cs are not the same. A point of care A1C is different than a lab A1C. A calculated A1C from a CGM is different. GMI is not the same as an A1C from point of care. But again, the why. So I asked, why? Why did you do it this way? Well, the mobile screen is only a certain size, and we couldn't fit everything in. And people had said that the weight was really important. So they trended the weight, but had the A1C, and so they had asked someone, when is A1C important? And the clinician they had asked had said, well, the most recent one is the most important. So by asking the why, it helped me get out of my head of, geez, like, how could anyone not know that the A1C is this trend? And I just needed to dig a little further to sort of ask, and we fixed it and it was fine. And, life went on. We did a single A1C view for the user, but for the clinicians, we did a trend on the console. So you know this, but the console view is different sometimes than the app view for the patient. So
yeah, I love that. I've certainly, marched into a call and said, no, this is not how we do it. You have to do it this way. And I missed the why, to be honest. And I had to learn what you clearly learned, right? Which was there's a reason behind everything. And mostly, ideally, you're in an environment where everybody shares the same North Star around delivering great care or delivering a great product, right? And if you kind of frame around, like, do we have the same end goal? Then it's not that, they're not trying to like step on my toes. I'm not trying to step on theirs. And if you can kind of understand their reasoning with curiosity versus coming in like guns blazing, like, this is how we do it. You must have like negative intent, right? Like, expecting positive intent of others is a good framing, for sure.
yeah. And I think if I'm going to be 100% honest, I think part of it is, listen, making this career change, there's a little bit of an ego piece. You're in kind of a little bit of a fragile state. And I think sometimes I sort of interpret it as like disrespect, like, are people respecting my credentials? Do they take me seriously? And over time, I realized they absolutely did. Everybody was very glad that I was there, very impressed by my education and my knowledge. And I was somehow connecting these small interactions with some kind of hit to my ego or to how people were seeing me in the organization. And that was completely uninformed. And I think that was a lot of it too, is I was sort of in my head about, hey guys, like, I'm a very well-trained, quite impressive, academic physician. Why isn't anyone listening to me? And it really wasn't about that. It wasn't a disrespect thing. It was just the way that product teams think and how they function. Yeah.
It's such a good call out. I felt that same thing. And I know people on my clinical product team felt that way too, right? There's maybe a misinterpretation that, that they're being disrespected. Yeah. And we're like, it's not our universe, so we're trying to find our place and establish ourselves too. I think it increasingly is our universe and it needs to be our universe, right? But I do think for a lot of people, it's the other. Whereas for technologists or design folks or product folks, like, this is the world they grew up in. So there's some discomfort in the world. For us, we're like trying to tiptoe our way into this new land and we're trying to make sure we fit and make sure we're respected for what we bring. Yeah, such a good call out. I felt that way too. And I came to find too, it wasn't disrespect at all.
Yeah.
Right? I mean, I always was valued, right? And but I had to figure that out too.
Yeah, I think the currency for clinicians, especially academic ones, is ideas. Like, we trade in ideas, and I think that R&D teams trade in impact and outcome, shipping and the product. And so ideas feel very personal to us, whereas I think in the tech world, ideas are just on the table. It's a sticky note on the wall. Whereas for us, ideas are very personal. They come from our heart. We get very attached to them. And I think that's another thing that I sort of had to sit with, is how personal I was taking everything. And people were surprised by that. They were kind of like, why are you feeling so? And I think it's because we link these ideas with care and with people's safety and with their health. And I'm not quite sure that the culture of technology development really makes that extension, but I think that's a good thing that we bring, is to remind people at the other end of this is a human being who is going to receive this care. And we feel that stress, but tech teams don't make that leap. They're not thinking that way. And I think we do bring that. And once they start to understand that, that also helped a lot with my conversations, is having them be more present with the fact that, oh my gosh, I'm impacting somebody's actual health, like a real human.
Yeah, there's a weight we carry on our shoulders of the responsibility of the patient's outcome. And I wrote about this once. I think it's a thing, as you're pointing out, that non-clinicians, they can't know because they've not been there. And it's, I don't judge them for not knowing. We've been in the trenches. We've felt the weight of that responsibility, and you go home with it too. I think that's the other thing that's sometimes hard for others to appreciate, right? That you carry it and you carry it always. And if something went wrong, like we would feel it. And I think we bring that to like even these non-clinical, quote unquote, decisions and conversations. So, well, I imagine that you've been in situations where you've had some conflicts with your teams. So, tell me some of those stories, and would love to dig in there.
Yeah, so we had a nice conversation about this before. So I in my mind, I perceive myself to be a very easy to work with, very fun, engaging person. Even at my hospital, I was widely considered, part of the reason I got the Epic job is I was widely considered to be friendly, positive, easy to work with. We have this word in healthcare, malignant, like people who just don't create a good culture. And it was very interesting when I got to Omada on several occasions. It became clear to me how conflict averse tech companies are. And I was surprised by that because I had this impression of, well, geez, people speak frankly and they push their ideas and people duke it out and that's fine. And I realized actually that clinical culture is much better at healthy conflict. We debate ideas, we meet every morning, we talk about the patient. Sure, someone might be called out if they have the wrong idea, but a younger person on the team might take it personally, but they learn over time that, hey, this is about the patient. We have to debate. And people may disagree and they might disagree vigorously, but you can do that professionally and you can do that without taking it personally. And you can emerge with a better plan because, hey, someone's healthcare is, someone's life might be at risk. And so there were several times over my time at Omada where I would get feedback that I engage in conflict, and I'm a person that might be difficult to work with. And there were times where I was kind of like, okay, is this a gender thing? Is this sort of people don't want a woman to show up in a certain way? I had to sit with that, and then I realized that not everyone knows how to do healthy conflict and have a debate, and people get a little undone by it. I also had to really get closer with power dynamics and realize that in my mind, I thought I didn't have a lot of power on the team, but I started to realize that my voice really was carrying a lot of power, and that with one comment, I could really affect someone and make them feel dismissed or feel judged in some way, regardless of whether that was my intent. So I know you asked for a specific example. I'm trying to think of a really good one. There are so many.
There's so many, right?
There are many, many, many examples. Well, I'll give one that was a healthy conflict over, the medication list. Okay.
Oh, so, I've had this one.
So we were back to the example of the diabetes program. So marching toward this very, very, very important deadline. And now, as a reminder, Omada is a wonderful company, provides amazing education and support for diabetes education, but we are not a medical provider of diabetes. We do not titrate medication. We do not take responsibility for someone's diabetes. In that role, we were providing diabetes self-management education support, which is broadly an educational experience. We are not providing care. So my diabetes educators had never provided diabetes education without access to a full medical record. So we were all imagining, hey, you need to have a full med list. You need to have the full insulin plan. They had never provided care without all of that documentation. Now, getting that documentation from electronic health record is a technology challenge. And also, just as providers, we know, having an updated med list is an investment of time. You have to do an interview, you have to get the data, you have to check it, you have to look at the pharmacy. So when we first started the diabetes program, my clinicians were like, well, we need a full medical record, we need a full medical list, we need a diabetes distress survey, we need all these things. And the team was saying, this isn't really like that. This is a employer benefit. The patient has, the member has, 5 minutes to fill out a screen. And if we make them do all of this, they're not going to sign up for our program. And by the way, they don't even think we're a medical provider. They think we're an app. So can we move in the middle? So the medication list.
Yes.
So initially, I thought we needed everything, the insulin levels, everything. What we ended up going out the door with was just the name of the medication without the dosing, the route, and the schedule. And the reason we got to there is because to get the dosing, route, and schedule and have it to be up to date, you'd have to ask the user to continuously tell you what is your insulin plan. Why would a user want to tell Omada what their insulin plan it was over and over and over again? Because again, they don't think we're their doctor. So we had to get out of our head. And I had a lot of conflict over that. I mean, I sort of even put my foot down and said, I'm not sure we can launch. I got really, entrenched, my whole team. Well, we can't do this without this information. And the healthy conflict was my partner at that time, Mike Tadlock, who is the head of product at Omada. He and I went on a walk and he said, Carolyn, I just want you to imagine for me what would need to be true for your team to be able to provide diabetes education with just the name of the medications that the person is on without the dose, route, and schedule. What would need to be true? And I think that was a really healthy way to have the conflict is let's debate it, but let's debate it not about feelings and about territory. Let's debate it about the problem we're trying to solve. And we can debate it vigorously, but we don't need to have our identity involved in all of that. Yeah.
Yeah. It's so funny. I had the same conflict with the product team about medication.
About medicines?
Exactly. Identical. And I remember the Zoom meeting. I remember the attitude I brought, which wasn't a good one in retrospect. And same sentiment of putting my foot down. That we needed the med list, we needed the dosage, we needed the frequency, we needed all of it. We were delivering care, but we weren't prescribing, we were delivering therapy, but we were delivering it to patients who had complex medical comorbidities. And I felt like it was really important to understand the context of their medical clinical history. But it was a huge sore point for our clinicians because it was a pain. To enter everything, to ask everything, to enter everything was a time sink and technology, barrier. And yes, and I remember my dear product peer who had all the best of intentions, but was like, do we have to ask the medications at all? And I remember just leaning in. I was not in a good mood.
Never did that. I think they smelled how strongly I felt about it. So nobody.
It was such a benign question. It's just curious. He was leading with curiosity, it was a why question, which just quaffed.
Well, and what's interesting about it is this, and I told you about this too, is what was so fascinating about this is after this whole thing, we sorted it, but everybody around me and Mike were like, oh, Carolyn and Mike are fighting. And I was really surprised by that. Because in my relationship with him and our conversation, and this happened with me with the subsequent head of product, and it has happened to me with every head of product I've ever worked with, where people perceive this healthy conflict as not a good thing. And that's something I'd like to change, is I'd like to figure out how can we create a culture where people can debate vigorously, that people can even have their feelings hurt. But that doesn't mean that we're disrespecting, and that doesn't mean people are getting along. Because in our dialogue, we were never not getting along. We were just not agreeing. And you can't change healthcare if everybody is being polite. Right? There are points where you have to engage in healthy conflict and you have to push each other and you have to debate. And that doesn't mean that there's an issue. That just means that, you're solving a hard problem.
Yeah. I think it's great. It's such a great point, the sort of healthy versus unhealthy conflict and this sort of misperception that you're not getting along. Whereas what you're really doing is finding a way through to an answer through conversation and dialogue, right? Which is very healthy, in fact, right? So, I mean, the other thing that we've talked about that I experienced too is different perceptions of or different pressures around time and delivery. And in the tech side, there's an agile product development process. Things function in these 2-week aliquots to get work done and get work shipped. And I think part of the challenge sometimes is coming in to the process in between and almost throwing a wrench, right, in like existing timelines and sort of being perceived as creating conflict, but it's just almost a mismatch of the timing of the request coming in for an opinion and the timing with which a tech team maybe needs to get something shipped for a beta test or what have you, right? I imagine you've had that experience too of bumping up against additional timeframes.
And you brought up two things that I think are really tough for clinical teams working with product. The first is not being included from the beginning. And feeling like you're brought in at the end, and what a dissatisfier that is for everybody, where you feel like, gosh, if you guys because now you're put in the position of stopping something or undoing something or asking for something to be rebuilt, and that doesn't feel good. And it doesn't feel good for anyone, let alone you asking for it. The interesting thing about the inclusion that I have learned over the years is you can't dictate that. So again, the currency at a tech company is not ideas. It is ideas, but it's also impact of those ideas. So if you want to be included, you have to look at what value am I bringing to the process, because there's a reason why people aren't including us. And I proudly would say I almost always get included at the beginning. And the reason that I get included is because the person on the other side of the table perceives that I'm going to add value at that point in time to the process. And so we don't, it's so sad, but we don't earn that right just with our credentials. And I wish we did. But the way that Scrum teams work and the dynamic process is they bring people in at times that they think that they're needed. And so we have to make it clear why we should be included earlier, because I agree with you, getting included later it doesn't work.
It's a recipe for disaster.
It's a recipe for total
frustration. And absolutely.
It's terrible. Now we'll get to your other question, which is, so at that point, this speeding up, do you get the best thing when you're running fast? I would say no. I gave you the example at one point when we were talking about a code, right? So codes, you would think that a code in a hospital is chaotic. It's actually not. It's an extremely quiet, structured, stressful, tense, but very, very structured process with a very clear leader. And oftentimes, a leader will slow the process down as long as the patient is stable for a second to think, right? And to say, hold on, everyone, let's just pause for a second. Let's look at the data again. Let's be thoughtful, because someone's life is on the line. So I think that clinicians in particular physicians, I would say, have a true talent of saying, let's slow down to go fast. And I think that I will, with all the respect in the world, say that tech companies lack that skill many times. And it's sort of a move fast, break things. I think that there is a time and place for that. But when you're doing health tech, there's also a time to say slow down. I recently had that experience very early on at Verily, where a product line that I feel very strongly about, we're having a meeting about. And I just said, guys, we need to slow this down. It's going too fast. We haven't thought some things through. Yes, this will delay things. Now, I use my newness to sort of say that. And I think I was able to do that because people are like, oh, she's new, she needs to get caught up. But the impetus, the desire to hit the deadline was forcing the team to move too quickly. And perfect is definitely the enemy of finished, but rushed is the enemy of good, right? And so there's some middle line between that. And I think we bring that to a team where our lens and our ability to look at a system and our leadership to sort of slow it down. How many times have you walked into a room and said to the team, everyone needs to stop what we're doing here, because you could see it. You could see what was happening with the patient. And you're kind of like, this just all needs to stop. And you have that leadership skill. We all need to step away. We need to have a conversation because what we're doing here is not working and we need to rethink. And I think we have a special skill in that. Yeah.
Well said. Yeah, I think my peers have sometimes wondered if I function well in chaos. Actually, I think we function very well in chaos, right? Like I think people have said you have to be able to handle change better, or you have to be able, and you're giving great examples. Like I've led codes, I've been in disaster situations in the ER and in the cath lab and, elsewhere. Yeah. And my heart rate goes down in those settings. My heart rate goes down because you have to be the one to kind of bring the temperature down to then create space to do the right things. And so I find that really interesting, right? I think there's some skills that actually are quite relevant from our clinical days to bring over to our tech.
Very relevant. I was shocked when someone said, what was it? Yeah, it was kind of what did you just say? You said like you get stressed out in stressful situations.
Yeah, like be able to manage in the face of chaos.
I was like, no, I thrive in those situations, actually. Right. That's where I show my stuff. I'm a hospitalist. Like I do my best when things are at their worst with a patient. That's my super skill, is my superpower, is being able to have clarity of thought and calmness and good energy when something really difficult needs to be done, especially in pediatrics. I mean, you have children screaming and crying and you're trying to do a procedure. Like being able, it's very difficult to do a procedure on a kid who is scared and fearful, and it's a lot of chaos and the parent's emotional. And, so yeah, I was always surprised by that. Like, oh, Carolyn, you're so stressed out. You need to just chill out. We're going to,
Well, and I think as we as clinicians also forget that we've learned actually some critical skills in our prior work lives that actually translate surprisingly well to this chaotic environment, right? So, well, I want to pull on one thread that you were just talking about like the timing of being integrated into the process. Now, I think I had the same experience where I kept getting pulled in late, and then that led me to be on this continual train of saying, no, that's not how this works. That we can't do it that way, and stopping the train. And that was that was deeply frustrating, I'm sure. Right. And I had to come to a point where I sort of said, like, I'm not old, stodgy, backwards thinking doc. Like I'm actually I left my Harvard Medical School job to come do this, crazy, highly risk-taking endeavor. So I'm not innovative. So that there must be something wrong with our process. That I'll take responsibility for the pieces that aren't me, but I also want to just let's all be thoughtful. Like, are we doing this right? Like maybe we should have clinicians involved earlier, to your point. And I know you established a process that I'd love for you to talk about having your we call them PRDs, or product requirements docs, right? Where they were doing all the thinking and then coming to us. And I know you've done a creative thing, as we did at Able to, of having that process involve you and your clinical minds earlier. I'd love to hear how you guys
I love this question because it gets down to the brass tacks of, okay, we've talked about this. Now, if someone was watching, how would they really implement that in their own team? So there's a lot to say there. I think of maybe sort of 4 process pieces that we set in place. The first is I realized that a lot of the team did not have the clinical context to be building, like the A1C thing. They didn't have a lot of context to be building. So we invested very heavily in what I called chalk talks. And so before the development, and that got us in right away. So I said, listen, what if we did a chalk talk at the beginning of the sprint, where we go in for 5 minutes and we just get everyone on the same page about the clinical topic. So first, that gets us in the room right from the beginning. And secondly, establishes us as an expert and someone and a resource for people, and they know who to connect with. And it gives everyone the information that they need. So it was win-win for everybody. So we started doing these chalk talks. So you're building a feature on A1C. Okay, let's have a chalk talk on what is A1C? Why does it get measured? What's the deal? And we would send a clinician in and sort of do that chalk talk before. If it was a big initiative, we would do a full-on webinar on the topic. We did a summer school series at Omada where when we built diabetes, we put everyone in summer school at Omada. And so we had a monthly webinar series that was for the whole company on what is diabetes? Like, what's the pathophysiology of it? We were partnering with PBMs. What is a PBM? Half the company didn't know what a PBM was, which is okay. That's not a bad thing. but PBMs were a very important part of our business. So let's educate people on what they are and who they are. And so that was really helpful.
Start with education, like offering to educate.
Yeah, you start by saying, hey, I have information that I think will be helpful for everyone. And then later, when you have a feature request, there's a context for that because everybody's on at least closer to a same page. Then the second thing that we did is we created a CRD. So there are PRD. For those watching that don't know what it is, product requirements document is the sort of the Bible, I would say, of what is happening with a product feature. So we had a product development cycle, and I advocated for us to have a clinical requirements document that was an input to the PRD, and it was before the process. So the CRD contained the clinical science and evidence for the feature that we were creating. It created a priority list of what was the most important things clinically. It defined the KPIs of what we were going to evaluate at the end of the feature. And it also established some expectations around the user experience, like what the longitudinal, in a polite way, because really that's design, but in a polite way, like what could it look like?
What was the clinical experience intended?
Yeah, what would be the ideal clinical experience be?
Yeah.
And so that document was required reading for everybody as they were making the PRD, and then the PRD would be based on that. So right from the get-go, we were included with the CRDs. Then this took a little bit more time. We built out what I call the clinical product team. Now I have to say, and I think Mike was on this call, he would agree, Mike did not care for the term clinical product manager. He thought that was confusing.
Yeah, we actually didn't use the clinical product name, although that was what my people did too. We called them we called it the clinical program development team. And now as they're all out looking for jobs, I'm like, just call yourselves a clinical product.
So we had that debate, and if Mike was here, he would giggle. He did not care for the word product manager being in the title. I fought for it. I probably used a lot of my political capital and friendship. And I did that, as you can imagine, very strategically because I wanted those people to be partners. I didn't want them to be thought as program manager at a tech company implies almost project manager. And I did not want them to have the name program manager because it implied an operational role, an execution role, not an intellectual partnership role. So I really fought for that. So we had a clinical product team, and I'm not the only one. There are amazing people like Rebecca Mitchell, who's a clinical product leader, Justin, who is at Andreessen, who's now at Sprint. Like there are people out there that have made careers with this. And if I'm not the trailblazer here, I would say it's folks like that. And so I hired a bunch of people and gave them the title clinical product manager. And then I mapped them to the product teams. And I said, hey, you now have a half FTE person assigned to your squad. And they now were going to all the sprint meetings and they were attending all of the conversations. And so when that A1C thing came up, and I will tell you, Rena, like after a while, the teams were like, oh my gosh, this person's so helpful. And I sent those people to training. So they went to training on agile development. They went to product management. We did free Coursera and stuff like that. And so I made sure that they understood the product development cycle. I made sure that they understood that the product manager was the decision maker and they got comfortable with that because that's the reality of the world we live in. And they, got embedded within the team. And that was really, really helpful. And then toward the end of my time at Omada, as Omada blessedly got very scaled up, and what happened with Omada was, this is the last piece of how we got integrated, is Omada got to a point where, for a while, the tech was out in front and the human care piece was a little bit behind because we were in a build mode and in a scale mode. Then we got to the point where we had millions of people coming in. And so now we had really important human care problems to solve, operational problems, scaling problems. We wanted to configure the program, have different interventions for different people. So now the human care team was doing a lot of innovation in program design that didn't require any tech configuration. So our roadmap went from a product roadmap to a program roadmap. And that was a very important transition because then the decision-making on the program roadmap became shared between me and the leader of product, as it should be, because half of the innovation we were doing had nothing to do with technology. It was clinical workflows, it was protocols, it was all of that. And the business needed that. And so having that joint decision making on the roadmap, also by definition, all the way down, cascaded down to inclusion. And I think I'll finish by saying, and passion topic, sorry to talk.
I love it.
But I think that the theme through all of that is at no place in the process did we come in and say, well, we should be in the room because of our credential or because of this. And we didn't necessarily earn the right to come in, but we made a very, very good case for how our presence was going to make the business more successful, was going to make the product more successful. We learned the culture, we learned the language. But when it came to important things like sticking up for the name of our team or sticking up for shared decision-making, we did that. Now, that shared decision-making on the program roadmap, at that point, we had Rendir as the head of product. That was several walks with me and Rendir to get to a point where we were able to align that we would have shared decision-making on the program roadmap. That was not an overnight thing.
I know the feeling. There's so much of your story that echoes what we did at Able To, and a lot of the great successes were similar in terms of like training up our clinical staff or clinical product people in agile product development processes, and what's a scrum and what's a sprint, and like how and then embedding them within the product infrastructure was so critical. And then all the same. Peter Shalik and I actually did a podcast as CPO and CMO. And we talked about, like there were lots of long and uncomfortable chats, which we shared. And we got there, though. We got there. And we did a lot of what you're describing, too. And it was hard, but it was so impactful. And I see so many companies, I would say the majority of companies haven't figured out what you figured out and haven't yet implemented this deep integration of clinical brains and product brains, which is so necessary, especially as we're building innovation that is touching clinical, is touching care delivery. So many lessons that you've shared that I think will be hugely impactful. I mean, I hope the clinicians are listening, and I hope the non-clinician peers are also listening for how to bring the two of us together to make this.
Yeah. I mean, I would say as clinicians, we do need to open our mindset a little bit. So I was telling you in the last month, I have hung out or spent time socially with, strangely enough, I don't know what it is, it's summer, with every single product leader I've worked with. They're all friends. We all trade ideas. And at least with two of them, as I can think about talking to them, they're struggling with their current clinical partner and asking me what to do. And I think that part of the challenge that they've said is how, in fact, one of them asked me, how do you help a clinician get more open to adapting and doing this? And I think clinicians can be a little entrenched. I think we're very prideful. And I think that if the best advice I would have for a clinician, even if they're seasoned and feel like they know everything, is just like, is pride getting in your way a little bit with this situation? Do you have a learning mindset? Are you curious? Are you engaging in a way that is open? Because we do tend to get a little prideful, I think, and a little closed off. And that doesn't help things.
That's very well put. I had a friend tell me once, like, you got to check your ego at the door.
Yeah.
It wasn't directed to me. It was just like in general, maybe it was, but I think in general, just like physicians or clinicians more broadly, like just check your ego at the door. And then, I think you'll be far more successful, but
we do have pretty high egos. I mean, listen, like, I'm not going to lie. We were the best students in our high school. We've been told we're smart our whole lives. We went to fancy schools. We were professors at amazing universities. Like, people have been puffing us up our whole lives. And, it's hard. It's hard to go into this environment and not bring that and be proud of that. And honestly, to be honest with you, Rena, the company relies on that as well. They want us on the internet. They want us to write books. They want us to speak about our companies. They want us to be ambitious and have that high ego, because that also benefits the company.
Absolutely.
But in the brainstorming room where everyone's doing sticky notes and everything else, if you bring that, it's very off-putting. Yeah.
You just got to tone it down. Yeah, for sure. Yeah. Gosh, you and I could talk forever and ever. In the last few minutes, though, maybe share a little bit about your current role at Verily and what you're up to there. And I know it's new for you in the last several months. So I would love to hear what you're up to
Yeah.
there.
So it's so fun. I'm so excited about it. I would never describe myself as a technical person. I'm married to an engineer, but I am so excited to be at what I think is that going to be the epicenter for AI in healthcare, just because of the intellectual resources that are at Verily. And so the problem we're trying to solve is how do we get as much of AI as possible in direct patient care? And you could think of it like, our sister company Waymo is out there with an autonomous driving vehicle, right? Like, how far can we push it in healthcare? How much AI can be in care delivery? How far will it go safely, effectively? And I'm the kind of person where, we're academics, right, at heart. I want to be at the place that's doing the most interesting thing and solving the hardest problem. And this problem is very hard. It's so I'm working on figuring out how do we get as much AI as possible into AI-enabled care? How do we fit it within our regulatory box? How do we make sure it's safe and effective? How do we make sure it works with the culture of clinicians? And specifically, my role is launching our Light Path Care solution, which is essentially AI-enabled care for cardiometabolic disease, which makes sense because that's my clinical expertise. But on a day-to-day, it's been really fun because I'm back doing exactly what we're talking about. For a while there at Omada, it's nice. You're in the boardroom, you're talking about budgets and planning, and now I'm back at the whiteboard and doing all of that, which is what I love.
Back to your building roots again.
Yeah.
That's amazing. I mean, it's so fun. This is such a fun conversation. I mean, I think you're just like on the cutting edge of ideas, number one, especially like in the new role at Verily and, incorporating AI into care delivery to do it better, to do it in innovative ways. And then also on the cutting edge of process change, like, which I think is so cool, right? Like, how do we do the whole process better and differently in order to get to that common endpoint we all seek, which is better care delivery for better outcomes for more people, which is pretty cool. So it's just, I mean, again, I think I could ask you 100 more questions and we could be here for 100 more hours, but I'm just so grateful.
We're friends, so you
I
can
know, so grateful. And it's such a full circle moment because you hinted at this, of course, but your brother Jay was my intern when I was a medical student and then was a resident when I was an intern. And it's so fun to like have that whole tie come full circle and for our paths to be so similar. And
it is fun. And I think, as I think about my brother and you and me, I think we were all cut from the same cloth, which is we went into medicine to practice medicine, but also to make the healthcare system better and, in different ways. And I think, I just love that you are now investing in the professionals that do this work, because as we've talked this entire time, it's not a direct leap over. People need help. Organizations need help finding the right people. And then the people, once they're placed, need help giving their best to the organization. So yeah, I'm so excited to see what you're doing now.
Thank you. I appreciate that. Yeah. And each of these conversations is another way to help people do their best, right? I think learning from the experience of those that have been doing this before them, if people like you and me can speed the path to innovation and the path to success for people and companies, patients will benefit. So I appreciate you doing this with me.
Oh, thank you. I mean, I never, ever, any person that messages me and says, I'm thinking about going into tech, they will get a dinner or a lunch or a walk out from me, and we'll have a version of this conversation, because I agree with you. I think my impact is smaller if I just focus on the work I'm doing. If I can, it's the academic again. If I can give someone some advice and help them, save them some cycles in their new job, like that to me is another way to impact. So thank you for this opportunity.
We're teachers at heart. And with that, just a huge thank you for giving me an hour of your time to share your story and your experiences and your wisdom. Really, it's just pure wisdom. So I appreciate you.
Thank you.
I'm so grateful.
Thanks.
Thanks for listening to another episode of Leadership Rounds, where clinician executives share wisdom and insights on what it means to be an exceptional leader in healthcare. If you enjoyed today's discussion, please subscribe, comment, and share with your friends and fellow leaders in healthcare. Join us next time for another dose of leadership wisdom. Until then, I'm Dr. Reena Pandey. Thanks for listening.